In the RCoA OSCE, there'll be one station where you'll have to demonstrate your clinical skills by making a physical examination of a live subject. When you enter the station, the examiner will likely be sat at a desk and will guide you through what's required from you and will communicate with you throughout the examination. The patient you will be examining will either be lying on an examination couch or sat up on the couch or in a chair. The patient is played by a volunteer, and candidates must be sure to treat them with the same care and attention that they would if they were a real patient. Please ignore the patient until the examiner indicates you should begin the physical examination, as the examiner may have some initial questions before this. After you have made the physical examination, there'll be some supplementary questions regarding procedure or associated diagnosis.
Good morning.
Morning.
So you've read your brief outside.
Yes.
Could you just carry on for me, please, and explain your findings as you do?
Okay. Hello, Mr. Jones. My name's Dr. Friedman. I'm one of the anaesthetic doctors here. Can I ask you to lie yourself down for me, please? So I'm lying the gentleman at 45 degrees. Is that comfortable for you there?
Yep.
Okay.
The correct angle is chosen for the couch, and the comfort of the patient is assured.
So I'm looking at the hands for any evidence of tar staining that might indicate a significant smoking history or any other signs of respiratory disease such as clubbing in the fingers. I'm then feeling the pulse and checking the respiratory rate, which I would do for 15 seconds and then multiply by 4 to get me breaths per minute. I'm also going to feel the other pulse. And then if I could ask you to pop your hands up like this for me for a few seconds. And I'm checking that there's no carbon dioxide retention flap. Okay, that's lovely, thank you. Pop your arms down. I'm then going to come up to the gentleman's neck, where I'm going to check to see if there's an elevated JVP, which I can't see.
This is a subtle part of the clinical examination, but the candidate examines for it and understands the significance.
Can I ask you to open your mouth and pop your tongue to the top of your mouth for me? That's lovely, thank you. And there's no evidence of any central cyanosis there. I'm then coming to inspecting the chest. I can see that there's a scar on the left-hand side of the chest. Do you have any tender areas on your chest at all?
No.
Okay. And looking at the expansion now.
Examining for chest expansion is often undertaken poorly. As demonstrated by this candidate, the tips of the thumbs must not touch, and their relative movement must be followed with the hands aligned along the ribs.
Okay. And the chest expansion looks good and symmetrical. Okay, I'm then going to tap on your chest, if that's all right.
Sure.
Percussion seems resonant throughout.
So why was the percussion note dull over that area?
I would expect this area to be dull because the liver is underneath.
Carry on.
Okay. I'm then going to listen to Mr. Jones's lungs. Take some slow, deep breaths for me, sir, not so deep that you make yourself dizzy. That's lovely. Good. And then whisper 99 for me, please.
99, 99, 99, 99, 99.
What were your findings on that last piece of examination?
The breath sounds are vesicular and there are no added sounds and no evidence of consolidation. Okay, I would then sit Mr. Jones forward and carry out the inspection, percussion and auscultation on the back as well.
Rather than moving from anterior to posterior and back again, potentially tiring a breathless patient out, the candidate inspects, palpates and auscultates anteriorly first.
Is there anything else that you would wish to do?
Bedside tests for the respiratory system might include a peak flow and spirometry.
The candidate has chosen tests that could easily be undertaken at the bedside and are quick to perform.
So good morning. You've read your brief outside. This is your patient, so please carry on.
Okay. Mr. Jones, isn't it? Okay.
It is common courtesy to remember the name of the patient one is examining.
Okay. All right.
A poor candidate will not explain what they are doing.
Okay.
So can you just tell me what you're doing, please?
Oh, okay. I was checking the respiratory rate, which is around 16 breaths per minute.
Carry on.
I'm just going to test your how much your chest expands. So, can you take a deep breath?
Examination for expansion is often poorly undertaken, allowing the hands to slide over the chest without the thumbs moving apart.
Okay. And then I'm going to listen to your chest. So take really deep breaths in and out for me.
Oh, I'm feeling dizzy.
Oh, just stop for a second. Okay, and again. Okay, thank you.
And what have you found?
Oh, I need to do percussion as well.
Percussion has to be over the hyperextended distal interphalangeal joint, with the finger well applied to the chest wall. Here, the candidate has performed percussion poorly.
So can you just tell me your findings so far, please?
The respiratory rate is 16, the breath sounds are normal, and the percussion note is normal.
Thank you. Is there anything else you would like to do as part of your examination?
I would like to do a 6-minute walk test, please.
The candidate chooses a test that is hard to do unless well prepared. It's not uncommon for the station to finish before the allocated 5 minutes. Once the examiner has finished questioning you, you will not be permitted to go back to something you think you may have missed. The examiner cannot comment on a candidate's performance or on any other details of the scenario. If you feel that you have not performed as well as you would have liked, remember that there are no killer stations in the OSCE, and no candidate passes every station. Once you have finished a particular station, try not to dwell on it. Put it out of your mind and move on to the next station.